Welcome to the next episode of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and I will be hosting this next episode that I hope will be a real treat for everyone who's watching or listening. It's a Friday afternoon here in Jacksonville, Florida. It's been a great week. It's been a challenging week with lots of complicated patients as usual. And one of the nice things about working where we work and working in an environment where we have colleagues side by side, both in the clinic and in the EMG laboratory, is the ability to run cases by each other. We do this constantly throughout the day. There are cases every day that something doesn't make sense. The patient's a bit complicated, something unusual shows up, and picking each other's brains is just really a good way to make us learn, make us think about things, make us help us consider potential studies, looking into techniques or findings in certain patient populations. And I sure did a lot of that this week, and I'm looking forward to ending the week with two fantastic experts in peripheral neurology and in EMG. This is going to be a special edition where we have two guests and their father and son. They have a long career in peripheral neuropathy, and I'm sure that not only will I hopefully make them think a little bit about the patient that I'm going to present, but I'm sure we'll learn from them and they will make us think about how do we approach patients both in clinic and in the EMG lab that come in with certain types of peripheral neuropathy. So sit back, relax. I hope you will enjoy this episode. Well, it's a pleasure to end my week with something I've really been looking forward to, another episode of Lessons from the Lab, and it's a real treat this week, not only to have two guests, but to have two family member guests. This is the first time we've had family members on this show, and it's a pleasure to welcome Doctors Peter Dick and Dr. Jim Dick. Hi, Peter and Jim.
Hi, Devin.
How are you guys doing?
You answer and I'll
I am well, Devin. Thank you very much. How are you, Peter?
fine.
Good. I I know your family, and it's been a long week probably for all of us. I want to ask you each, Peter, has Jim behaved this week? And Jim, has Peter behaved this week?
I think we are looking forward to the spring. It's been a mild year. It's been a good year of recovery. Mayo Clinic seems to be doing well. I've been found to have a lymphoma, but it's treatable. So God is good. I'm fine.
So I think Peter has always been a little mischievous, and he still is at age 96, and I think that's great. So my answer to you, has he behaved? Yes, he's behaved, and he's true to character.
And I would just say that Peter didn't answer the question of whether Jim behaved. He kind of skirted the question, so we'll interpret that however we want to interpret that. But Peter, we wish you good health and recovery, and just know that I'm sure not only me, but everyone who is listening to this has you in our thoughts.
It's actually a sad week in some ways. Dr. Andrew Engel is about to retire from Mayo Clinic on Monday of next week, and due to ill health. We just looked at his curriculum vitae and his accomplishment, and they really are phenomenal.
Well, we're fortunate that he's been with Mayo for so long, and that you're still here and willing to do an episode with us. So thank you.
Yeah, I'm sorry to interrupt you there, Devin, but Peter and Andy really have had parallel careers. Peter in nerve, Andy in muscle, and they have been the stalwart powerhouse of Mayo Clinic's neuromuscular department, with Ed Lambert doing the electrophysiology with them. So they really set the standard for the world for many years. So I echo Peter's sadness about the departure and retirement of Dr. Engel. For me, one of the great joys of my own career has been able to work with my father for the last 30 years. And that's not just having his support, but having his objective criticism and discussion. And so it always made the things that I was doing better to have a discussion, a critical discussion with him about whether the projects were worthwhile or not worthwhile. So it's been a real joy to be able to work with him.
Yeah, and I think that's so important. You know, you think about our careers and who we work with and who we can run things by and who teaches us and who we teach. And I think that's what makes a career so good and so effective. And I know Peter, we haven't worked directly together. I didn't do a peripheral nerve fellowship, but I've certainly learned so much from you peripherally, and just to think of so many people who has learned from you and your research and your experience, and it's just outstanding. And we're looking forward to teaching others during this session as well. So it just keeps going.
Thank you.
So. Well, so the goal of this Lessons from the Lab is to, as I just said, to teach anyone who's watching or listening on the podcast the way that you or we all might think about a case. So I thought what I would do is I would present you both a case. It's a patient that I saw several years ago, and it's an interesting case, and it raised a lot of questions. And so I'm going to just share my screen and I'll give you the brief history, and then we'll talk about it, see how you would approach the patient. So it's just a one slide case history, and I'll read it here so you don't have to read it yourself. But the patient when I first saw him, he was a 41-year-old man who had a long history of type 1 diabetes, dating back to when he was 10 years old. And it had been pretty well controlled. His hemoglobin A1C around the time I saw him was 6.8. So not great, but that was kind of where he was at. But he complained of numbness in his feet for 2 years. And he was very active. He was a runner. He was a cyclist. And he noted gradually over 2 years this numbness. And as we all know, the question is, what does numbness mean? And he said he didn't have any pain. He felt a cold feeling on the bottom of his feet, which extended up to his ankles. He felt like he was walking on ice blocks. His feet were on ice blocks. He felt that there was some weakness in both feet, and he was very active, but occasionally would misstep when he walked. And he thought his balance was a little bit off, but he still was still running. He had no other symptoms in his arms. He had no back symptoms, no bowel bladder, no autonomic symptoms.
I think Peter wants to make a point here, Devin.
I'd love him to do that.
Yeah. At first look, 6.8, if that's his usual A1C, that would be quite out of line with his neuropathy. You know, in our epidemiology studies, we use 6.5 as the criterion for diabetes. So 6.8 in a type 1 diabetic is actually quite a good value, especially if it's been that level for a long time. So my immediate suspicion is this person's neuropathy is not due to diabetes, but we'll just continue to listen. But
I want to make a couple of points here. One, this guy's 41 years old and he's been a diabetic for 31 years. So, I mean, he has certainly been a diabetic for a very long time. So in your Rochester diabetic neuropathy studies, you showed the degree of glucose abnormality and the longevity of glucose abnormality were a lot of the points. So the fact that his hemoglobin A1C now is 6.8 doesn't really tell you a lot about the prior 30 years.
Fair enough. I accept that.
So Devin, one point that my father always hammered into me when I was being a trainee in this topic was, does he have coexisting nephropathy? Does he have coexisting retinopathy? Because the three of them tend to track together. And so I think that would be very important in this man.
And those are great points. And the answer to that at this point was no, that he didn't.
Okay.
And the other question I was going to ask, and you preempted the question I was going to ask, which is great, is what about, do you put much weight on the quality of the symptoms, the description of the symptoms, thinking of diabetes versus a non-diabetic cause?
Oh, no, I'm not sure about that. But I think the words patients use mean something. Dr. Alan Bailey, who was involved in writing the first textbook for neurology at Mayo Clinic and wrote the section on symptoms, always stressed the point that the patients, the words the patients used for the symptoms had value. And there's no question in my mind from the words you used, presumably echoing the patient's words, indicate that the patient has positive neuropathic symptoms. And in my mind, positive neuropathic symptoms always have even greater meaning than negative ones. And by positive neuropathic sensory symptoms, I mean a positive feeling of, quote, a sleep numbness, prickling, jabbing pain, altered feeling,
coldness in this case,
coldness, and in a precise or a localized fashion, bilateral, soles of feet, toes. So I think they're whereas negative symptoms simply might mean, well, can't feel as well as other people or something like that.
But this patient has some of both, though, does he not, Devin? Because
right, I would think.
I don't get from the sense of this presentation he has much pain. His coldness, he may describe as pain. That bothers him clearly. So I agree with Peter that this is some positivity. But it seems to me that it's mostly numbness being the negative symptom. He doesn't feel as well, with a bit of positivity with the coldness, but it's not so much pain. Now, one point I want to make here is that most of us think of typical diabetic polyneuropathy as being a painful syndrome. In fact, based on Peter's work and the work of others, the vast majority of diabetic polyneuropathy is lack of feeling, negative symptoms, numbness being that I don't feel well on my feet, but not painful feet. It is that 10%, 15% who actually has painful feet and go to their doctors and complain about it, that has all neurologists thinking that diabetic polyneuropathy tends to be this painful condition, when in fact, most diabetic neuropathy is not a painful condition.
So if his symptoms were burning, tingling, sharp pains, and that was his main symptoms, would you, just with what you know now, would you lean more towards the diabetes being the cause? Or you still can't even tell that?
Yeah, I think to me, again, so for 10 years ago, Peter was talking about typical and atypical diabetic neuropathy. Typical diabetic neuropathy was painless, no pain, and atypical diabetic neuropathy was painful. And he was calling it that based on just the prevalence. 85% didn't have pain, 15% did have pain.
This might be a good time to ask the question whether this man, who was 40-some?
He's 41.
Yeah, has sexual troubles.
No, he did not. And no,
Or-
no sexual or other autonomic
Okay.
symptoms.
The other thing, of course, we are having this conversation about this patient, and therefore, I suspect this is not just the typical diabetic polyneuropathy. Otherwise, why would we be having this conversation? But that is probably not a fair way to think about these things.
Well, but no, I mean that right. And but this is how it presented, and this was the predicament at that time,
Yeah.
right? So we know he has diabetes. We'll go into the EMG in just a moment.
Well, I mean, I do think this is an important point because I have this point all the time in clinic. Just because somebody is a diabetic and just because they have a neuropathy does not mean that neuropathy is due to the diabetes. And I think it is good for us to try to think through this in a systematic way. And so, is there associated a retinopathy? Is there associated nephropathy? Those are important questions. How long have they been diabetic? That's an important question. What is the glucose control? That's an important question. And I think Peter's point is a good one. If this guy has no sexual dysfunction, I am a little suspicious that his diabetic neuropathy is due to diabetes.
And one could ask the question, this is the place where you want to have a broad net. And I would be concerned about Fabry's disease, Tangier disease, hereditary sensory and autonomic neuropathy type 1.
Yeah.
So a good question would be to inquire about the family history.
So that was going to be my one of my next questions. So it sounds like it's important to ask about family history when we're assessing people with neuropathy, right?
Oh, of course.
Yeah. So I mean, obviously, but
Just going back to that point, Devin, and I'm sorry for interrupting you. We had this conversation about positive and negative symptoms. And 25 years ago, Peter wrote 2 papers about an approach to peripheral neuropathy, the 10 P's paper, and the 10 steps paper. And one of the big points he made in them was positive versus negative symptomatology. And I would argue that although this person does have some positive symptomatology in the cold feet, a lot of this really sounds negative with numbness of the feet. And negative symptomatology often goes with inherited neuropathy.
With inherited
neuropathy.
Right.
I remember that paper. I think I was a resident when I read that paper.
Yeah.
If anyone listening, if there's one paper to read on neuropathy, definitely read that one. So how, in terms of family history, what's the best way to elicit a family history? Is it to say, do you have any family history of peripheral neuropathy and that's it? Or is there a better way to do it?
I think one could consider 2 ways. If you think that there's a strong probability that it could be inherited, then a good way is to take a separate sheet of paper and start with parents, their names, their birth dates, their symptoms and findings, and in other words, just go at it in detail, because you're likely then to be able to find provocative evidence or suggestive evidence that will lead you to study members of the family. To illustrate that point, the first patient at Mayo Clinic I saw with high arches was in a teenage boy, and it had the appearance of the patient had the appearance of Charcot-Marie tooth disease. I took the family history, and I noticed immediately that there was a strong history, but all the relatives who had symptoms were explained by something else. Uncle Henry, team of horses had run away, and they caused his crippled legs. Uncle Victor fell off a roof and broke his ankles. But sitting beside the blue chair was the boy's mother, and I could see that her arches were high, so I simply had her take off her stockings, and found out that she couldn't walk on her heels and she had absent ankle reflexes. So if you have a strong suspicion, go at the family history in detail. If it's a remote possibility, I think that is too time consuming to go at it. But typically in neurology, family histories are generally worth the time taken. I don't know if that answers your question.
Yeah, and it does. No, absolutely. And Jim, when you're asking, let's say you don't have a family member that's there in the room, you can't examine anyone. Are there specific things that you ask the patients?
Well, no,
Uh,
I think Peter's points, I just want to reiterate them. He's the one that taught me my approach to this. You cannot ask, to answer your question directly, you can't just say, is there a family history of neuropathy? That is essentially a useless question. I mean, very rarely somebody's going to come in and tell you that. But most of the time, you've got to say, tell me about your father. Could he walk on his heels and toes? Did he have numb feet? Did he have painful feet? Did he soak them at night? Did he have problems later in life? And you just go through every one sequentially. And I remember this one patient who came in who had painful feet, who had very high arches, hammer toes. Her mother was sitting in the lobby, and so we dragged her mother in, and she had flat feet. Her arches had fallen, but she couldn't walk on her heels or toes. But she never had any pain. Her daughter had pain. And then the patient's own daughter had very high arches, no symptoms. And all three of them had peripheral myelin protein duplication, and they all had Charcot-Marie-Tooth type 1A, and they all had completely different symptoms. So I think you just have to be very, you have to persevere, you have to ask questions. And I think Peter has a point here. They're cutting down the time we have to see patients more and more. But I still think in somebody that you have a suspicion of inherited neuropathy, it is definitely worthwhile going after this.
Let me just correct your statement about HMNS and 1A is not P0, but
I didn't say that. Peripheral myelin protein 22 duplication of Charcot-Marie-Tooth type 1A.
okay.
yeah, we
I'm
got to
sure
make
the
sure we're
audience
clear of that.
all
Yeah.
of this.
In terms of family history, well, let me ask you this, and I don't know, Peter, I assume you've probably done work on this. In patients that end up having an idiopathic neuropathy, or we don't find an acquired cause, do you have a sense, or do you know what percentage of those it's likely hereditary or it's proven hereditary?
It depends, first of all, whether it's autosomal dominant or some recessive trait. In autosomal disorders, you typically, and if they have a reasonable sized family, the family history is often positive. Recessively inherited disorders are much more difficult, but there the clue often is relative of parents and just the nature of the phenotype. For example, Tangier disease of an old person is so different than Tangier of a young person, and the phenotype is the clue. In a young person in Tangiers, they have yellow tonsils. In the original patients I saw, one patient referred from Bill Lando at Washington U, and the second person from Saskatchewan, they did not have yellow tonsils, although when we biopsied their tonsil, cholesterol esters were 40 times the normal values. So you would have thought they might be yellow, but they didn't show. So I think it really is very dependent on which gene abnormality one is talking about.
What about the hardest situation that I think, and there may not be an answer to this, but the 70-year-old that comes in with numbness in their feet, uh, you don't find a cause. Do you think that a lot of those are probably inherited? If they don't have a strong family history or any family history, do you think that still there's a genetic predisposition or we just don't know in those patients?
I don't think I have a very good answer, but I've encountered people who are in their 70s who had unknown inheritance, and sometimes the phenotype, provides the clue. Other times you simply get genetic tests. And increasingly, as you know, the cost of genetic tests went down. When I first began to do genetic neuropathy, evaluate genetic neuropathies, uh, genetic tests weren't available for any of them. Today, you can get the whole genome, for something like under $300. So the costs have come down remarkably. So I think the phenotype has to remain a clue as to whether you order the tests. And common clues of long-term neuropathy are high arches, the distribution of the weakness or sensory loss, the symptomatology.
Yeah, I'm
Yeah.
going to say something very similar to this. I do think the phenotype is still very useful. So I will see patients who are 7 years old who come in with a very long-standing neuropathy with mostly negative symptoms, who have skinny ankles, inverted champagne bottle legs, high arches, hammer toes, family histories of hammer toes, but not definitely neuropathy. And their EMG often will show very large, simple morphology motor unit potentials, to give you some EMG to your EMG talk here. Not a lot of denervation, maybe some dystole. And you just have a feeling that this is an inherited neuropathy, even though you often will run a genetic panel on them and it's negative. But at the end of the day, I still think that's probably an inherited neuropathy that we just don't really understand yet.
Mm-hmm.
Can I just add to that?
Sure.
When I began at Mayo in the early 60s, the view among Mayo Clinic neuromuscular physicians was that the neuromuscular disorders were often overlapping, and they used Venn logic, where you have overlapping circles.
The Venn diagrams with all these overlapping circles.
Right. That turned out to be completely wrong. It turns out, that inherited disorders are unique. You don't have essentially motor neuropathy overlapping with hereditary motor and sensory, and among whom hereditary motor and sensory, they're discrete disorders. So it's clear that the number of disorders far out are much more frequent than we originally thought, and continue to be, especially the recessive disorders, are still being discovered.
Mm-hmm. How to shift a little bit, how useful do you think in these situations is electrodiagnostic testing? Do you do an EMG in every patient with neuropathy? Does it add to your diagnosis? Is it important? Or can you say this is classic neuropathy? His clinical exam shows distal weakness, areflexia, distal sensory loss. He has neuropathy.
In my opinion, it is the most important individual test. The clinical examination is important for the distribution, but neurologists simply do not accurately measure mild degrees of neuropathy. Typically, neurologists overestimate most signs. We have hard evidence on this. So the most sensitive measures of neuropathy we have is the DCCT, composite nerve conduction scores of conduction velocities and distal latencies with abnormality of conduction velocity in more than in one nerve. We have now tested this in a cohort of patients that we especially studied, and we're testing it also in diabetics. And it is a very sensitive measure. A stronger measure of severity, however, is composite score of amplitudes, CMAPs and SNAPs. That's a separate topic worthy of a long discussion, but we found, that clinical neurologists typically overestimate signs. They want to believe the patient. The patient is there to see you for a reason. The tendency is to express that wish, and people overgrade.
So, Devin, about 10 years ago, we brought in 12 neuromuscular experts from around the world, and we had them evaluate 24 patients, half of whom had neuropathy, half of whom didn't. And the question is, did they have diabetic polyneuropathy? And on the initial, they went through twice, and the patients were then masked and they had their voices altered so the physicians wouldn't recognize them on the second time around. And the physicians were very non-reproducible on who they called neuropathy and who they did not call neuropathy. And they also were very bad at actually identifying those who had neuropathy. And I think this goes to Peter's point that neurologists tend to grade findings based on what they're hearing from the patient's symptoms rather than really being kind of tough and looking for definite abnormality on examination. And when these then 12 expert neuromuscular neurologists from around the world were told how poorly they did and to make their own criteria much more strict, when they did it a second time, they did much better. So, we can be trained to do better, but we are too sensitive. Back to your original question, are nerve conductions in EMG helpful? I would say absolutely they are helpful. I do think in a severe neuropathy, you can kind of tell, but I still think it's very helpful to know, is this a demyelinating neuropathy? Is this an axonal neuropathy? Is this uniform demyelination or is this non-uniform demyelination? Non-uniform demyelination is temporal dispersion, conduction blocks, prolonged F waves, and that's much more indicative of CIDP or an inflammatory demyelinating process. And I think those things from a clinician's point of view are very helpful. Again, about 15 years ago, I was part of the Peripheral Neuropathy course, the Academy of Neurology, and the other members on the faculty with me were advocating that in the typical case of CIDP, you could just examine the patient and see the proximal and distal weakness, put them on IVIG, and you didn't even need to do nerve conductions in EMG. And I strongly disagreed with them. I think you really do. I mean, IVIG is a very expensive treatment. Why would you do that? I mean, make sure of your diagnosis, get it right. I do think it's one of the things that we offer here at the Mayo Clinic is intensive evaluation, and a big cornerstone of that is an EMG.
Yeah, and I mean, these are fantastic points. I would make one point and then I have a question. To the point of being very careful on the clinical exam, I think we all know how fortunate we are where we work from the EMG standpoint, that we were taught to be compulsive, starting with Ed Lambert, and that you have to be careful with doing electrodiagnostic studies and being compulsive, because you could get a lot of people out in practice doing the same patient and get all sorts of different conduction velocities because of temperature. And so that's really important to be compulsive in the studies to not misdiagnose neuropathy also.
The same thing goes at the bedside too. I mean, you want to take a careful exam. You want to examine individual muscles. I mean, people say, oh, toe extensors and toe flexors, they don't matter, but they in fact are the weakest muscles in most length-dependent neuropathy. So you want to take your time and examine all the different muscle groups. It's not that much work. My
question is, because I agree with your point, one of the big benefits of EMG is determining predominantly demyelinating neuropathy from axonal. is there any reliable clinical finding when you put your hands on the patient to be confident that a patient has a demyelinating neuropathy?
I would say no, except for maybe hypertrophic nerves. I mean, you can sometimes feel these large nerves going across the ulnar, across the elbow, at the back of the thigh, but, the great auricular nerve in the back of the neck. But by and large, I don't think you can really tell demyelinating versus axonal on a bedside exam. How about you?
I think the more difficult problem is whether it's primary or secondary demyelinating. By that, I mean primary demyelination is there is an abnormality, a genetic abnormality of the Schwann cell, excuse me, so that the demyelination is systematic.
Yeah.
Excuse me. Whereas in secondary demyelination, it tends to be irregular and it affects the conduction velocity of the nerves.
Yeah. So that gets, go ahead. Go ahead.
No, you go ahead and I'll get over my cough.
Yeah. You're getting excited about this point. Yeah. So I want to show you the conductions that were done when we first evaluated this, because it relates to what we're talking about here. And I'm going to just
I don't know if you want to, but we haven't done the exam. It's because we interrupted you. So I don't know if you want to continue.
We don't need to examine the patient. We just go to EMG, right?
All right, very good.
No, the exam is right here. The exam shows mild to moderate foot dorsiflexion and eversion weakness. He had some difficulty walking on heels, a little bit on toes. He did have pes cavus, hammer toes, a little bit of finger extensor weakness, absent lower extremity reflexes with reducing the upper, and then he had distal sensor loss to all modalities in his feet to his ankles. So
it actually reiterates some of the points we make, which you should consider inherited.
Yeah. So anyway, let me just show you these conductions, because I want to get to this point and see what you think. So this was a while ago on an older system, but his fibular motor conduction shows an amplitude of 0.2 millivolts.
Yep.
The velocity is 30 meters per second.
Yep.
And okay. And there's no dispersion.
So again, it's a very small response. It is clearly slow, but this response is very, very small. The thing that is striking to me is that's pretty uniform. There is no evidence of dispersion there.
So the question, go ahead.
This is the perineal nerve.
Yes.
Yeah. And then I'm going to show you the tibial here, which also amplitude 0.7 at the knee, millivolts, velocity is 29.
Yep.
And latency is 6.8. And I don't know if you would say that's dispersion. I'm not sure on the tibial. I would call that. But
I would not say that's dispersion. Again, I think it's pretty uniform. And the advantage of this one is the amplitude is a little bit bigger.
And I'm going to,
yeah,
a little bigger. And then the Searle maybe was there at 8.4.
Yeah.
And then I want to show you the arm here. So the median motor was normal, but the velocity was 46 meters per second.
A little slow, yeah.
So that's slow. But the amplitudes are normal, no. Yeah. And the ulnar, similarly, median, he had some big F-waves, which.
Yep.
And then the ulnar, same thing. The amplitude was 7.1 at the elbow.
Yep.
The velocity was 44. So the question is, can you tell by this if this is primarily demyelinating or primarily axonal, and how good are our conductions?
You're a sneak. This is an intermediate slowing. So
what does that mean?
It's on the border between axonal and demyelinating.
But the point is good. It is more in favor of an axonal process in which the demyelination is sort of the same among fibers.
Yeah, well,
whereas it's not like what you typically see in the disorder which has dispersed conduction velocity.
No, I agree with that.
So for my position, it favors something like Charcot-Marie-Tooth over diabetes.
No, so I agree with this. I think, well, so you don't have temporal dispersion, and I think that's an important point. In the lower limbs, your amplitudes are down, and that is the primary disorder. There is some slowing, but I think that is of a lesser degree. In the arms, the amplitudes are actually normal with mild to moderate slowing, but not in the typical demyelinating range. And so historically in CMT, they talked about the demyelinating forms, they talked about the axonal forms, and then they talked about those types that were between the demyelinating and the axonal as the intermediate forms. And whether that's a useful description or not, you can debate. But that's what I'm saying this is. This sort of is on the border between the axonal form and the demyelinating form. But what I would say is exactly what Peter says. There isn't evidence of temporal dispersion. You know, this looks more like an inherited condition. Now, in diabetic polyneuropathy, you often get a predominant axonal neuropathy with some secondary demyelinating changes. So in fact, I don't think it's quite as strong as Peter says, because I do think there is that kind of flavor to this, that it's primarily axonal, but there is some slowing, so maybe some demyelination. Nonetheless, putting the whole picture together, I think it's more in keeping with an inherited neuropathy and less in keeping with a diabetic polyneuropathy.
You know, we studied this question in sural nerves with Peter O'Brien, the statistician. And we asked the question in Charcot-Marie-Tooth 1A, PMP22 duplication, is the demyelination random, or is it more selectively on certain fibers? And we showed it to be random. And whereas in a disorder, which like CIDP, where the demyelination possibly relates to T cells with the action of antibodies, one would not expect such a random attack on Schwann cells. So we were able to show that the demyelination was not random.
So a further point to back that up,
was more focal.
So Peter was involved in this too, but Jennifer Tracy and I and others looked at nerve biopsy patterns in inherited neuropathy versus CIDP, and specifically onion bulb formation. Onion bulb are stacks of Schwann cell processes. It's an abortive remyelination process. And we found that the pattern of onion bulbs in acquired inflammatory neuropathy is different than in generalized inherited neuropathy. So in generalized inherited neuropathy, all fibers have onion bulbs, where in CIDP, it's patchy. Some fibers have them, others don't. And in fact, that explains temporal dispersion. Some fibers are more affected, others are less. And so some conduct better, some conduct less well, where in inherited neuropathies, they all conduct poorly, all at the same slow speed, and you don't get temporal dispersion.
Devin, maybe you should tell us if we're completely off target here.
Well, don't worry, you won't leave before you have the answer, but knowing you, you're never going to be completely off target. So, but
I think the question also implies, are we boring everybody with all of
no, this is fantastic, because these are all the questions I wanted to ask and get into. But the follow-up question to what you're saying, and I'm just going to show you one other slide with the needle exam, is the needle showed some fibrillations in reduced recruitment and long duration motor potentials in distal but not proximal muscles. So if you were doing this EMG, what would your interpretation be? Would you say this is an axonal neuropathy? Would you say it's demyelinating? Do you put in your report, this is intermediate and there's a mixture of axonal and demyelination? How do you do that in the EMG report?
I'm a great believer in mugwumping. In the 1880s presidential race, which we're all going through right now, there were a group of people who didn't want to back the loser. And so they were called the mugwumps because they sat on the fence and they wouldn't back anybody until a winner declared themselves, and then they backed that person. But I use this as a verb to mean to say as much as you know. And when you aren't sure of something, you sit on the fence and you mugwump that. So I think I would say this is predominantly an axonal neuropathy. There are some demyelinating changes, and I'm not quite sure of everything, but I do think it's predominantly axonal. What's your view of that?
I'm not sure this helps me.
Yeah.
I think I still favor this not being diabetic.
Yeah.
I think there's a component of both here, and I think
Yeah.
it's fair to say that.
And I'll be honest, this was the predicament that I had. This was a few years ago, and what I think I said exactly what you said, Jim, that it's a predominantly axonal neuropathy. He has fibrillations. He has evidence of reinnervation, but with some demyelinating features.
So this is a complete aside, but I have had cases where it's a very aggressive focal demyelinating lesion with secondary axonal loss. So I've seen in these cases fibrillation potentials distal to these lesions, and when I've biopsied the lesion, the primary lesion is actually demyelination. And so life is always more complicated than we want it to be.
And with CMT or HMSN1, there's axon involvement, right? And reinnervation. So that's why we see you could see over time, long duration, high amplitude motor unit potentials from reinnervation.
Yeah, so some of Peter's very early work in Charcot-Marie Tooth 1A showed that there was secondary axonal loss in that condition.
Yeah. So I'm going to jump ahead because I mean we could talk for hours, and this is fantastic. But I'm going to tell you what happened and show you his second study. So he went off. We didn't do genetic testing initially. We kind of counseled him symptomatic treatment, and he came back 3 years later with worsening neuropathic symptoms. Still no pain, but his feet were weaker. He was curling his toes more. The numbness had extended up to just below his knees, and he had some slight worsening of his exam, of his strength. And he had an EMG again. And now, so this is 3 years later, we have a new system, so it looks different, but and it's hard to see this, but his fibular motor amplitude is 0.05, but the velocity is 24. The tibial motor velocity is 21. And now his ulnar motor velocity, which was 45, I think, is now 34. So what do you think of does that?
It's certainly looking more demyelinating.
Yeah. And
what's happened to his A1C?
His A1C was stable. I think it actually went down. I think it was down to 6.1.
Wow.
Yeah, or so it had his diabetes was stable.
Yes, so I think I still favor non-diabetes as the cause.
Yeah.
The neuropathy is progressing, and it would be in keeping with an inherited neuropathy based on the longevity, the distribution, the lack of finding, I assume, other reasons for his neuropathy, like diabetes, which 6.1 is a very good A1C level.
Yeah, well, I think his nerve conductions certainly look more demyelinating than they did previously.
Yeah, and I think the thing that struck me, especially on the second study, is the velocity at about 20.
Yeah.
Right? We have these criteria, and I don't know how perfect they are, that of the degree of conduction velocity slowing if the amplitudes are low, that to indicate that there's significant demyelination, right? You have to be slowed by 50% or so if the amplitudes are low. I don't know if you believe that, but when it's 20, that to me makes me think demyelination.
Yeah, well, no, the 0.05 and 24, I don't know what I know about that. But when you have it, it's 0.4 and 21, I think, that's still a reasonable amplitude, and that's pretty slow. So I agree with you. And then
Yeah,
the older at 34, it should be,
it's intermediate.
it's intermediate, but it's getting slower. So
Yeah, yeah.
Could we request a genetic panel?
Yeah, can I ask you what gene, is there any gene? Do you just want the whole thing, or would you want to do specific ones?
Well, I
Uh,
would do the whole gene panel,
okay.
but I this could be a PMP 22, but well, there you go.
So we did it, and he had uh CMTX.
Well, which is actually you kind of laid that out for us there. This is the one that is thought to be the most associated with the intermediate slowing. So, yeah,
Yeah.
the Connexin 32. So
We lucked out again.
So
no,
yeah, no, I mean you were spot on. I knew it. See, that's why I don't give the cases ahead of time, because I know you know what you have the experience. But I think it was an educational case for me, because early on I was thinking the same as you. This didn't really sound to be, I wasn't convinced it was diabetes. The slowing was a little more, the lack of, to me, I would put a little more weight on the lack of positive symptoms, but it sounds like that I shouldn't put as much weight on that.
well,
And
no,
this,
I think you should put weight on that. I try to emphasize it. I think Dr. Dick was thinking the coldness sounded like positive symptoms to him, which is fair enough. But my sense of the way you presented it is this was mostly negative symptomatology, and negative symptomatology certainly makes you think of inherited. Now, I again, with our conversation about diabetic polyneuropathy, I think a lot of them have negative symptomatology, but even most of those really have some prickling and tingling. They just don't have pain. That's the distinction I'm making there. So I'm with you. Hammer toes, skinny ankles, slow evolution, mostly negative symptomatology. That all makes me think inherited.
yeah, I we could talk forever. This is fantastic, and I want to just leave. We're almost up on an hour.
Oh,
You
I thought
both,
this was a 2 hour session.
well, part two will be 2 hours. Yeah. But we have lots of listeners at all stages of their career, some training, some out in practice for many years. And maybe you both have so much experience. Do you maybe have a piece of advice or some words of advice for a new, or any of us in neuromuscular medicine, whether it's for EMG and assessing neuropathies, it's clinical assessment of neuropathies, anything that you think is really important for us to always remember, keep in mind when we're evaluating these patients? And I know that's a broad question, but any kind of final words of advice?
Have you go for it.
Well, I've been recently working on the lack of objectivity in assessments. And the field of neurology, especially peripheral neuropathy and even nerve conduction, could be improved by more adequate composite nerve conduction scores. The DCCT, the Diabetes Control Complications Trial, asked themselves, and I was one of the people they asked, what nerve conduction should we use? What nerve conduction criteria should we use for the least evidence of diabetic sensory polyneuropathy? Fritz Buchtal from Copenhagen, who was then an NIH, said, all you need to do is study the CMAP of the perineal nerve. And if it's decreased, or if the conduction velocity is decreased, they have neuropathy. Now, there's an occasional person who would have an entrapment, but that's a pretty good indication. I said that wasn't good enough. They didn't take either my word or Fritz Buchtal's, but they canvassed a bunch of neurologists and they decided abnormality of nerve conduction needed to be in more than in one nerve. So those are the DCCT criteria for sensory motor polyneuropathy, a nerve conduction abnormality in more than one nerve. So we have subsequently looked at which is the most sensitive composite score of nerve conductions. And we found that the composite 5 score, that is ulnar conduction velocity, ulnar distal latency, tibial and fibular conduction velocities, and sural distal latency, is the most sensitive composite score of that. And it can be highly defined. So less than fifth would be 1 point, less than 1 would be 2 points. So you could get a score from 0 to 8.
Mm-hmm.
On the other hand, if you use CMAPs instead of the ones I've talked about, of the ulnar, perineal, tibial, sural nerves, that's a better measure of severity. And I think if neurology wanted to go in a direction, they would adopt some criteria like that to have some uniformity. Because at the moment, the idea that every lab who has done 40, 50 patients, reference patients, have an adequate reference score, not true. It could be improved.
Yeah.
So that's my recommendation.
Great.
Well, it's hard to follow that. I mean, I think I will be much more general. For your average neuromuscular physician out in practice, what are my words of wisdom to them? I think stay vigilant, listen to your patients, see what they're telling you. Don't think you know it all. The other day I saw some patient who I had seen a few years ago who had somewhat reduced amplitudes, large motor unit potentials on nerve conductions, EMG, several years ago. Outside studies showed the same. Some not so bright neurologist locally was calling it CIDP, had them on IVIG. And I just told this guy, well, I saw you 5 years ago. You didn't have CIDP then. You don't have CIDP now. That neurologist is crazy. And we did the nerve conduction studies, EMG, and it showed temporal dispersion, conduction of long F waves, and I was wrong. And so I think recognizing that we all can make mistakes and we can be wrong. And one thing that you can be wrong about is a treated CIDP can look awfully normal, and their nerve conductions can be normal. And so, it's happened to colleagues of mine and to me that you think that this person isn't CIDP, you take them off treatment and they crash. And I think you have to own your mistakes, learn from your mistakes, and always be willing to grow. My father said to me that any person who is not in a state of becoming is dead. And so the point is, you have to continually grow. You have to continually question yourself. You can't think you ever got there, you've ever met that achievement, and now you don't have to grow any further. We all can grow, we all can improve. We all need to persevere, listen to our patients, and try to do our best.
I think that's terrific. And just, I don't think anyone could say that any better. And you both have definitely grown with each other. We've grown with you, all of us who have interacted with you, learned from you. And I'm sure those who listen to this and watch this will continue to grow as well with the knowledge that you both shared over this hour. And I really, really do appreciate it. I know it's an hour of your time, but it's just great talking to you and seeing you, and looking forward to the next time.
Thank you, Devin.
Yeah, thank you for having us, Devin.
Thank you. What a wonderful treat to be able to spend an hour with Doctors Peter and Jim Dick talking about all sorts of aspects of clinical and electrodiagnostic approaches to a patient with a peripheral neuropathy. There's just so much knowledge there. Of course, Peter, his whole career for decades has been the expert in peripheral neuropathy. Jim has followed in his father's footsteps and is also really an expert in all aspects of different types of neuropathy. And there are so many teaching points on this case. It's hard to list the teaching points, but I think the points that I would take away from this is the importance of a very careful clinical evaluation of patients, paying close attention to the patient's symptoms, both positive and negative symptoms, performing a very careful and detailed family history, particularly if there's a slowly progressive neuropathy with a suspicion of an inherited neuropathy. And then I think we learn that the EMG testing is important, it's critical, but it's not always straightforward. And the delineation between a demyelinating or primarily axonal neuropathy can be difficult, and some of these conditions can fall into an intermediate zone that doesn't fit perfectly into one or the other types of neuropathy. So hopefully everyone learned from that, learn the importance of paying attention to our patients, thinking about our patients carefully, and understanding that we're continuously learning. And we certainly have learned from Doctors Dick and Dr. Dick, and we look forward to learning more, hopefully from them again and further in the future. Hope you enjoyed this episode. See you next time. Bye-bye.